And so we will be posting this on our website. Usually we get it posted within 24 hours or so. If you're having technical difficulty, the simplest approach is to log out and rejoin. Usually there's like a little glitch, and logging out and rejoining seems to solve a lot of problems. So try that. We do have closed captioning enabled, so you should be, although I'm not seeing it on my screen. Hold on one second. Oh, there it goes. So thank you, whoever made that happen. Yay, team. We do have closed captioning available in English. Unfortunately, we can't have English and French closed captioning at the same time. Our way of working around that is we do have a French translator who is present with us, who will transcribe everything said in English into French in a Google Doc. Gabrielle, may I turn it over to you to introduce yourself and explain the process?
Absolutely. I'll switch to French now, just for the French speakers in the room. Je m'appelle Gabrielle, j'utilise le pronom Yel, puis je fais la traduction aujourd'hui en simultané de la présentation en français. Par exemple, la traduction simultanée n'est pas faite directement sur Zoom. Il faut cliquer sur le lien qui est partagé dans la boîte de clavardage en ce moment, qui va vous ouvrir un Google Doc, puis vous allez pouvoir suivre l'intégrale de ma traduction en direct. Donc, n'hésitez pas à cliquer si jamais ça peut vous intéresser. Merci. Thank you.
Thank you, Gabrielle. And yeah, we will also be posting the French transcription on our website, as well as any other materials. So I'd like to take a moment to acknowledge the role of colonialism in the work that we do and in our day-to-day lives, and the differential impact that it has on members of our communities. So we're coming together today from across Turtle Island as people who live on treaty lands and unceded territories. We work in a sector whose goal is to address social harms, and we must recognize that the production of these harms comes from the history of colonialism and its enduring practices, enduring institutions, and enduring ways of thinking. Colonialism is with us today. It's part of our day-to-day lives. And we must commit to working in ways that reshape these institutions and practices, to repair harms and to prevent future harms, and to work towards a more inclusive and just future. I invite you to put in the chat your name if you'd like to introduce yourself, and also where you are coming from. You could do a land acknowledgement in your chat, in the chat if you like. It's interesting to learn about where people are. So we have a certificate of attendance that's available for people who attend our events. If you would like the certificate of attendance, we will drop a link in the chat. Robin will pop it in the chat about halfway through, or more or less. And you just click on that link and it takes you to basically like a Google form, and you just fill out the form, and then it sends you a certificate so that you can use for whatever purposes that you find that useful. So very quickly about the National Safer Supply Community Practice. We're a knowledge exchange and capacity building initiative. We're funded by Health Canada's Substance Use and Addictions Program. We're a collaboration between London Intercommunity Health Centre, the Canadian Association of People Who Use Drugs, and the Alliance for Healthier Communities. And our goal is to support the scale up of safer supply programs and sort of more generally improved access to quality, equitable, and effective care for people who use drugs, social and clinical care for people who use drugs. Our focus is a medical model of safer supply, and that's due to the current regulatory and legislative context. We support many other models of safe supply, and always want to make sure we keep those conversations happening and advocacy for other non-medicalized models and decriminalization. We've got lots of things, lots of activities, lots of action happening at the community of practice, working groups, webinars, workshops, regional meetings and more. You can check us out on our website to see what we're up to. We also have a very extensive resource library, over 700 items in that resource library now, of all kinds of things, from reports, academic peer-reviewed literature, tools, all kinds of things there. So please feel free to check that out. We also have all of our previous webinars available on our website, so you can see those there if you like, if you miss them. So yes, here's our website. This is also how you can join the community of practice. If you go to our website, you'll see on the top right-hand corner the join button. If you register, you'll get access to members-only events, members-only resources, our newsletter, our discussion forums, and things like that. You can also follow us on social media. Great, I think with that, oh, this is just a list of some of our webinar recordings that you'll find on our website. And with that, let me stop sharing. And now allow me to introduce Nancy Henderson. Nancy is coming to us from Toronto, which is colonially known as Toronto, where they live, work, and play on the lands that should remain under the full jurisdiction of the Mississaugas of the Credit, Anishinaabeg, Chippewa, Haudenosaunee, and Wendat peoples. Nancy is the Safer Supply Program Manager at the 360 Degree Nurse Practitioner-Led Clinic in, I'm not sure how to pronounce this properly. It's colonially known as Peterborough, I'm sorry, I haven't practiced this, Nogowejawanog. Nancy, can you correct me? Do you know how to pronounce that more elegantly?
Oh, now you put me on the spot. No, I don't have it in front of me. Sorry. Nogochewanog.
We need to practice.
We do.
Nancy's completing their master's in nursing science degree at Queen's University and in Cataraqui, which is Kingston, Ontario, and has plans of continuing their academic journey with a PhD next year. Their topic of study is, and will continue to be, related to safer supply programs on land occupied by Canada. Nancy sits on numerous committees and working groups related to their work and education, including the steering committee for the Making the Shift Scholars with Lived Experience of Youth Homelessness Network, and working groups for the Canadian Lived Experience Leadership Network and the National Safer Supply Community Practice. Nancy comes to this work drawing from their personal lens of lived experience of youth homelessness and substance use. They continue to share their experiences in order to inform by us and for us safer supply programming, as well as to support the agenda for the decriminalization, legalization, and regulation of all drugs in order to put the role of drug choice and distribution back into the hands of the people who use them. Thanks so much for being here today, Nancy. Thank you all for being here, and I'll turn it over to Nancy.
Thank you, Rebecca. I'm just going to share my screen. Everybody see that? It's, yeah, we're good. Okay. Thank you, Rebecca, and that introduction was great. I am going to talk to everybody today about the need for decriminalization and safer supply, evidence from current research and practice. First, a quick disclaimer. The research I'll be speaking about was funded by Health Canada's Substance Use and Addictions Program, and the views expressed herein do not necessarily represent the views of Health Canada. A few objectives, just so people have an idea of what I'll be talking about for the next hour. We're going to look at the drug poisoning crisis and why we need to address the stigma and criminalization of people who use drugs, explore the barriers and enablers of opioid agonist therapy and safer supply through the Peterborough Research Project results, and understand the need to scale up safer supply programs and fight for decriminalization, legalization, and regulation of all drugs. Some of this may be things you already know and just a reiteration, or and hopefully some of it will be new for you. So because I work in a sector that is trying to address social injustices and harms, and before I can talk about harm reduction programs that are meant to counter the war on people who use drugs and the violence of its criminalization, I must first acknowledge that these harms originate from a history of colonialism and through the genocide and exploitation of Indigenous and Black people. From this, the values, institutions, and systems that were formed and continue today, including everything from policing to prisons, education, and healthcare and housing, were all founded on white supremacy, anti-Black racism, and ideologies of superiority. These systems are not flawed, but rather the deaths we see of Indigenous and Black people are inherent to it and will continue if left unchanged and unchecked. All of these systems need to be dismantled and rebuilt by the community, not in consultation with the community. So I am going to give another land acknowledgement because I am not calling in from home today. So I want to recognize the colonial violence that continues to this day, and acknowledging that the land that I'm speaking to you from today and on which I'm a visitor is the unceded Coast Salish territory of the Lukwagon and the Wasanich nations. Wasanich nations. From January 2016 to September 2021, 26,690 people died from opioid toxicity poisonings in Canada. And it is believed that by March 2022, we surpassed 30,000 people. 20 people died every single day from January to September 2021. And for a comparison, there were 7 deaths per day in 2016, the year that the drug poisoning crisis was first declared in British Columbia. This is no longer a situation where people are overdosing. This is a crisis where people who use drugs are being poisoned by a toxic street supply of drugs of unknown quality. The street supply no longer contains fentanyl. The street supply is fentanyl and its analogs, which is now also contains benzodiazepines and other adulterants. So how did we get here? How are we at a point where we're seeing 20 deaths per day due to the volatile and unregulated street supply of drugs? The ideas of drugs, addiction, deviance, and disease are all social constructs that can be traced back in history and also challenged by us today. In the 1800s, drugs went from being known as a source of relief from pain and as a cure to disease to being pleasurable and associated with being hazardous to health and society. This led to the prohibition and criminalization of drugs and the people who use them, starting with the Opium Act in 1908 and eventually becoming the Opium and Narcotic Act of 1929, which would become the driving force behind drug policy. During the early 1900s, while these prohibitionist acts were being created, drug use disorder was considered to be a defect in character since this person chose to use drugs despite prohibition and social disapproval. For people who use drugs were seen to be weak, immoral, and foolish. And that meant that there was no need to look at the problems of inequality, poverty, and familial breakdown that may be coexisting with the person's substance use. From this, we started hearing stigmatized language such as dependence and addiction. The idea that addiction is not only a chemical dependence based on physical relief, but also an experience that the individual wants to have for psychological relief led to a shift in cultural belief from focusing on the drug to focusing on the person. The term addiction pathologizes, medicalizes, and criminalizes the person who uses drugs, which then leads society to believe that the person who uses drugs needs an expert to fix this problem with the individual's addiction through the criminal justice system, healthcare system, and/or rehabilitation and recovery systems. Yet, according to research, only 10 to 20% of people who use substances actually become addicted. So let's skip ahead to the 1960s when an attempt was made to test drug addiction by a group of experimental psychologists. They wanted to use the Skinner boxes. Skinner boxes date back to the early 20th century. Skinner boxes were tiny boxes where rats who had been starved for 24 hours were placed, and then experiments were conducted on them to test operant conditioning. Inside the box was a lever. Every time the rat hit that lever, one pellet of food would appear as a reward. They also did punishment experiments where an electric shock was administered through the metal door when the lever was pressed. In order to do this experiment to test drug addiction, rats were tethered to the ceiling of the box with tubing, and a needle or catheter was surgically implanted into their jugular veins. They set it up so that when the rat pressed that lever, the rat received a small dose of a drug, which came through that needle into the bloodstream. Different drugs were used. They used heroin, morphine, amphetamine, cocaine, etc. In this experiment, the rats would consume such large doses of the drugs that they almost always died of overdose. And the conclusion was that drugs in and of themselves are irresistible and addicting. They concluded that this surge in dopamine stimulation caused by the drug in the brain's reward center was irresistible to people. These experiments supported the claims that people get hooked on drugs, meaning that there's a problem with the individual. And this is where the image of a person who's addicted to drug being enslaved to that life because of the drugs comes from. Then in 1971, the phrase war on drugs was coined by President Nixon when he stated that drug abuse was enemy number one in America. This language entered the Canadian sphere in the early 1980s, and it continues to guide domestic and foreign policy on drugs to this day. We have been hearing, and governments around the world have been using the phrase war on drugs for 50 years. Around the same time, in the 1970s and 80s, the Skinner box experiment was altered by Bruce Alexander and colleagues of Simon Fraser University in Vancouver, British Columbia. What they realized was that the rats weren't given a choice outside of drug use and that they had been completely isolated and starved. So Alexander's and his colleagues built Rat Park, where rats could live their best life with other rats and with lots of activities to engage in, because rats are social and sexual beings. In Rat Park, they had access to 2 water bottles. One had this sugar water and the other with water that had drugs in it. But this time, drug use was low and there were no overdoses. Through this study, Alexander showed the significance of the social environment for drug addiction and therefore argued that addiction is a social rather than physiological issue. The rats in the Skinner boxes experiment were living in solitary confinement, starved, and they had no options. But in this experiment, they actually had those, and they stopped choosing the drug. The local media ran with the research results, and it gained a lot of attention. But in the words of Alexander, the results sank like stone within the broader world of addiction theory. Although the study was replicated, the addiction world was not willing to reconsider the conventional ideas about the causes of addiction being within that individual. They just wouldn't let it go. Then in the late 1990s, Carl Hart wanted to test these rat experiments, but this time with using humans, because he believes that addiction is truly a human experience, and an experience that he states cannot be studied on animals. There are some parts of addictions that can be studied with animals, but we can't model the actual experience of addiction. So based on the knowledge that 80 to 90% of people who use crack and methamphetamine don't get addicted, Hart recruited people who had addictions by offering them a chance to make money. And he had it that it was a chance to make $950 while smoking crack from pharmaceutical grade cocaine. Most of the people who signed up were Black men, and most were from low-income neighborhoods. The people would have to stay in the hospital for several weeks while participating in this study. So the study was that for each testing period, it started with a dose of crack that was lit by the nurse. The participant who was blindfolded did not know the amount of crack that was going to be given that day, and it varied from day to day. Then every little bit, the participant was offered more opportunities to smoke that same amount of crack, or they could accept $5 cash or a voucher that they would collect upon discharge from the hospital. When the doses were high, the participants usually chose to keep smoking that day. But when the dose was smaller, they were more likely to accept the $5 in cash or the voucher. So about half of the time, the people chose the money or the voucher, and the other 50% of the time they chose the crack. They replicated this study with people who used methamphetamine, and they had similar results. Then an alternative reward was offered. It was increased to $20. When they offered the $20 of the drug, the participant always chose the money, no matter what dose or type of drug was offered. The results of this showed a shift from the idea that the person who is considered to be addicted cannot stop without using once they start. Because the money or voucher wasn't available until the person left the study, it also showed that the person who is addicted can delay gratification when given an alternative that would be of benefit to them. The results, they get rid of the rat experiment results and the image of a person being addicted to drugs and only wanting that drug, because when given an alternative that was deemed to be better for their economic future, they were able to make a decision based on these factors. There were people who argued that people were saving the money and that they would use it for crack when they left. But this was disproved again because many of the participants asked for the money and they were saving it to pay off bills. People need alternatives in their lives so that drugs are not the only option for relief from the distress caused often by the realities of their environments and often the lack of opportunities to better their situation. But even with these results, it is still easier to focus on that individual and the drug and that becomes the focus. And it's easier to change that than to fix the social problems that exist for people. An example of inequity and racialized decision in the criminal system is evident with the legal distinction between crack cocaine and powdered cocaine with the Anti-Drug Abuse Act of 1986 in the US. And I'm sure many of you know about this, but crack is associated with racialized communities and carries with it harsh penalties, including life imprisonment for simple possession, while powdered cocaine receives much lighter charges. And that is deemed to be mostly due to the fact that it's considered to be a white man's recreational drug. The messed up part of it is that they're the exact same substance, just one chemical apart. Yet in the mid-90s, you would receive the same sentence for having 5 grams of crack as you would for having 500 grams of powdered cocaine. That's a 100-to-1 disparity, and it perpetuates racism and discrimination. 85% of people sentenced for crack cocaine offenses were Black, despite the fact that the majority of the users were not. And in 2010, the Fair Sentencing Act was signed into law by President Obama, and this brought the 100-to-1 disparity between powder to crack cocaine to 18-to-1, but the disparity still exists. And this isn't enough. They're still being treated like they're different drugs. If we shift to opioid use and how it's been portrayed in the media, there has been a very different picture painted between the white non-medical opioid users and the Black heroin users. And this was written about by Netherland in 2016. In this article, she tells us that when there's a media coverage of white opioid users, we typically hear about a toxic drug poisoning death of a young middle-class suburban man who was tragically killed by the toxic street supply of drugs. And this is tragic. We need to hear these stories. The problem is that when we see Black and Latino people in the media related to opioids, we hear about the criminal offenses that were involved in without telling us anything about the person and what their life looks like, which is dehumanizing. The image created is of a more menacing Black or Latino urban criminal. And what follows is support for policies that respond to this image and leads to the criminalization of urban Black and brown individuals. Race is a factor in the creation of that social construct of drugs being harmful and bad. And it's pointed out in this article that the criminalization of Blackness and the decriminalization of whiteness is directly linked to the current drug war. This is an exception when we look at methamphetamines, however, because this is seen as a drug that is a divergence from whiteness through class. And this also leads to the social construct of drugs being harmful and bad. So even though the scope of the current toxic drug poisoning crisis far exceeds the crack days, we are not seeing the same criminalization of the white suburbanites as we saw in the 1980s and 90s with urban Black and Latino people. And I'm not saying that we should see the same criminalization. It's just pointing out that the difference in the response to the drug based on the image that is created. And not only are racialized people more criminalized for drugs, but they also don't have the same access to healthcare, counseling, harm reduction, and addictions medicine as the white people do. And this is also evident in safer supply. As discussed, the war on people who use drugs exists because substance use has been seen as a problem with the individual rather than a broader systemic issue. The Global Commission on Drug Policy wrote in 2017 that this partially explains the paradox where most citizens believe in the failure of the war on drugs, yet they continue to support policies that call for more resources being put into this so-called war. They want to continue to see this as a problem with the individual that can be dealt with by enacting strict policies and harsh sentences. Canada spends just under $46 billion per year on substance use, with the majority of this going to lost productivity, healthcare, and criminal justice. But at the same time, 64% of Canadian adults believe in harm reduction as a general approach to substance use, yet this is not reflected in the provincial government and health authorities' public policies and that govern harm reduction services. Drug prohibition has deep roots in colonization and racism, and this has led to today's war on drugs. As we all know, this war on drugs is a war on people who use drugs, who are believed to be deviant and immoral. It is a war against some of the most marginalized people in our society. The war on people who use drugs is based on what we now know are decades of failed drug policies and systemic racism. The drug poisoning crisis that is now in its 7th year is not a criminal justice crisis. It is a public health and policy crisis. So why is it that the number of deaths continue to increase? Why is this 6-year state of emergency still a crisis, and a crisis that is not abating? We have seen through the COVID-19 pandemic that when governments work together, there can be a robust and often effective response to a public health crisis. So why are we not seeing it with this drug poisoning crisis? It comes down to stigma. And in order to combat the stigma and harm directed at people who use drugs, we need a public health approach that is grounded in human rights and health and social equity. How do we get there? We need to start with policy changes that take us from the criminalization of certain drugs to the decriminalization of all drugs. And we need it to be a policy change that is in effect across the entire country. Under the current state of criminalization, we have been told that abstinence must be our goal. Because of this belief, the gold standard treatment for opioid use disorder is opioid agonist therapy, or OAT, which consists of Suboxone, Sublocade, methadone, and sometimes Cadian. These are long-acting medications that are a part of an abstinence-based model. So why are we not investing more money and time into OAT to curb the rate of deaths? When these medications work, they work really well, but retention are low. Client perception of treatment is sometimes waning, and many people have been failed by the abstinence-based punitive model. People who use drugs need another option, and this is where harm reduction and safer supply comes in. What sets these apart from opioid agonist therapy is that the participant's goal does not have to be abstinence. Their goal can be anything that they choose it to be. We need a variety of services, but criminalization, some people use drugs of services that are there for them, such as consumption and treatment sites, opioid agonist therapy treatment services, and gear distribution. Because of the stigma and criminalization that exists, people who use drugs who do access services do so at the risk of experiencing discrimination, dehumanization, and stigmatization. Before talking more about safer supply and decriminalization, I'm going to provide a few examples of how this has all played out in my own experiences. So during my early years, I experienced significant trauma that negatively impacted the rest of my life. I was what you would consider to be a good kid who got good grades at school, but as a youth, I struggled with an eating disorder and depression. I was in and out of hospital, so I missed a lot of school and then therefore typical teenage socializing. Then there was an incident that changed things. What followed was a series of events that led to me being removed from my home and placed into a women's shelter in a neighboring community, and then being removed from this shelter and taken to a hospital in a city about an hour away. Once placed in this city, I never returned home. I was alone, without supports, without family, without friends, without my dog, without anything familiar. I was a country kid and I had been displaced into a big city without being provided the resources to be able to figure things out. I've often wondered who exactly thought this was a good idea, because I certainly wasn't in a position to be making a decision like this. When I left the hospital, I was placed in a group home for young female identified people who were all in somewhat of similar situation. It was at this group home that I found exactly what I was looking for, though. It was here that I found my escape from the realities of my life, and I found that escape in drugs. And I got pretty good pretty fast. They put up with me for quite a while at this group home, but I was eventually asked to leave. And then I found myself nowhere to go. No money, no job, and no high school diploma. I quickly realized that I would need to figure things out myself on the streets and within a very broken shelter system. This would be my reality for the next few years. My drug use escalated and I used whatever I could get my hands on, but I definitely gravitated towards using stimulants at this time because it was a way to keep myself, I felt a way to keep myself safe and alert. I wasn't doing great with my peers in the youth shelter system, so I migrated into the adult shelter system where resources were a bit more sparse, for a person my age, but I found a few people who started to look out for me. This entire experience of being on the streets, in and out of shelters, living in extreme poverty, all while dealing with substance use and mental health issues, was trickled with criminalization and stigmatization. I was criminalized for sex work and fraud, both of which were means for me to get the drugs I needed to survive my life. Drugs weren't just used for pleasure, they were a way to cope, they were survival. The main harm reduction service I used at that time was the site ban, which was a needle exchange program that existed in the 90s in response to the AIDS epidemic, and which was actually a response from the UK to the Hep B crisis. And it was 1-for-1 at that time, unlike today. So if you took in 10 rigs or 100 rigs, you would get 10 or 100 in return, which meant that there was often not enough to keep up with my habit. And just the whole process of counting out what you were bringing back and getting counted out for what you could take it felt stigmatizing. The van would park in specific places throughout the city, and the police were told to leave us alone, but they were never that far away. And it was always that fear of, would somebody be around watching where I'm going next? So the people were great, but the experience wasn't. And it was because of that stigmatization and criminalization. I got off the streets in the late 90s, and I spent the next decade or so immersed in housing instability, poverty, food insecurity, mental health challenges, and trying to practice harm reduction for my substance use. How I managed to escape homelessness is a bit of a mixed bag of connections that I made with staff in the shelter system who, for whatever reason, went out of their way to try to help me, and connections with random people who crossed my path who would either make themselves or their home available for me when I would want to try to change things. Ultimately, I was one of the lucky ones who staff broke rules for, and sometimes those rules needed to be broken in order to truly help. I tried to get into day programs to get help, but addiction services wouldn't take me because I had an eating disorder, and eating disorder places wouldn't take me because I had addictions. Dual diagnosis just wasn't a thing. So I made the decision to create my own day program. It was January and I lived about 6 blocks away from the adult high school. My new plan, go back to school. With the help of the staff at the shelter I was staying at, I enrolled in high school, which would begin in a couple of weeks. I didn't have a lot of time to reconsider and I was petrified. So I spent the next couple of weeks getting as high as I could with the plan of quitting on my first day of school. That plan came mostly true. I definitely showed up for school. I didn't know how it was going to go. I didn't know if I could still learn the way that I had before, if I could keep with it. But I just went for it anyways. I put figurative blinders on like a racehorse. I put my head down and I focused on school. I remember there was one person in my biology class who every day when he would see me, he would say, "Hi, Nancy, how are you?" To which I'd respond, "Good, you?" And I'd keep on walking and not waiting for a response, not wanting a response. So I didn't have a long-term plan, but I was definitely meeting my short-term goals and I eventually graduated. I want to skip ahead and talk about a period in my story where I fell and I hurt my back. I went through a bunch of physical therapy and opioid for treatment, trying to control the pain and trying to get myself back to work. My life at this time was already a mess, but this definitely made it worse. And I found myself once again caught up in addictions. But because of the interaction between my meds and the fentanyl I was being given, everything abruptly stopped with a serious health concern. And in response, I was taken off all of my prescriptions and I, of course, went into withdrawal. Everything's a bit of a blur about what happened, but I essentially spiraled out of control. I couldn't eat, I couldn't sleep, I was sick, I was anxious, and I thought I was losing my mind. At one emergency room visit, I pleaded for opioids and they actually listened. I am beyond grateful because I know that the ending of this story would likely be very different if it weren't for this day. I have thankfully not had to rely on the toxic street supply of fentanyl at any point in my life. So the rest of my story is very privileged because of that. On this day, they gave me just enough opioids to keep me well. And I was in a space where I was okay with this. I was done. But eventually they said no more prescriptions and they sent me to addictions medicine doctor at a clinic. And this is where my experience with OAT comes in. Regardless of the medication that I ended up on or the process of getting there, I consider myself one of the lucky ones who came through the experience being deemed successful on traditional OAT. However, even with this apparent success, I was not spared the humiliating, dehumanizing, and stigmatizing experiences that are part of this punitive program. From the moment I walked through the door of the OAT clinic to the moment I walked out of the pharmacy with my prescription, I felt like I was labeled and treated like a drug addict because I wasn't believed and trusted. The most humiliating part was providing urine samples while being watched on a video camera that was in the wall next to the toilet. It was a childhood fear of someone peeking in on me while in the washroom come true every single visit. And I intended to be truthful about my drug use, but they didn't trust it. And the experience is that it's the very design of opioid agonist therapy that leads to this stigmatization of people who will be caught and penalized for anything that is deemed to be wrong. Even if the doctor doesn't want to do it, they sort of have to. And because of this design, and we need OAT treatment, but we need to have some change within it. And we need something different for those who have been failed by or don't want to be part of this traditional system. Life threw me a bunch of curveballs after walking away from what is considered problematic substance use. But when I would get into these places, I looked back at what worked in the past and I would decide to put my focus back into school again. The next time this happened, the only program starting at the community college where I wanted to enroll was the personal support worker program. So I went for it. I didn't ever want to be a PSW, but I needed a goal. I was doing well in this course, so the nurses who taught the classes encouraged me to enroll in the Bachelor of Science in Nursing program. Again, I had never wanted to be a registered nurse, but I had nothing else to strive for. And although I was filled with a tremendous amount of doubt, I decided to go for it. And 4 years later, I actually graduated. Through nursing, I found my way to give back to the community that I left behind. I have been working with people who use drugs and people who are unhoused since before I graduated, and I am so grateful that they let me into their lives. I realize every day that I lucked out. I didn't ever have to be entrenched in a crisis that is killing my family and friends. I didn't ever have to experience the immense grief and loss that is now embedded in the lives of people who use drugs. I didn't ever carry that same type of fear in knowing that this hit could be the last. All of this is not okay. And it is up to all of us to listen to what people who use drugs are saying and to fight for and create change in our communities. All of these experiences and my looking back on them have opened my mind to new opportunities that offer an alternative to the options that were available at the time that I was needing them. And that is something like safer supply and the need for decriminalization. With decriminalization, all of these experiences that I described could have been different because as it stands today, drug use is a criminal activity. So anything related to that drug use can potentially be criminalized. With decriminalization, we can break down barriers to people accessing harm reduction, safer supply, and treatment services without people fearing criminal charges, stigma, discrimination, and dehumanization. Once we take away the stigma and the criminalization, we can see the health concern, with the root causes being based in things like trauma, housing insecurity, and poverty. When we take the shame away, we can talk about it freely, which opens the door to honest and open relationships where health and social care teams can provide the person with the services that are needed. Drug policy is a public health issue and needs to be removed from the criminal justice system. What needs to be done is basic and core to health practice. The solution is pragmatic. We look at what is causing the harm and then look at how we address that root cause. We need to ensure that people who use drugs feel safe to access the services that will help them to reach their individual goals, whatever those goals may be. So I'm going to remember a few things about decriminalization. First, people who use drugs need to be not only heard, but they need to be central to this process every step of the way, because they are the ones who are subject to the brutal harms associated with the criminalization of drugs. Second, we need to center the voices of Black and Indigenous people because they're being disproportionately affected by the criminalization of drugs and drug policies. And third, we need to listen to the often silenced voices of female identifying gender nonconforming people. In BC, 80% of the women who are incarcerated are there because of drug use. And over 50% of those women are Indigenous. Putting them in jail for drug use disrupts families and divides communities. This is a systemic racism issue. This is a reconciliation issue, and we need to address the harms. And decriminalization is just one part of the equation. It is merely the first step. We also need low barrier and high quality harm reduction, safer supply, and treatment programs because people use drugs need options that meet their personal goals for drug use and care. We need a community-driven model that offers voluntary supports for people who use drugs. This model needs to be separate from the police and instead be centered around community organizations who are already working on the front lines of this crisis. We need to meet people where they're at and when they need it. In order to offer high quality programming, we need government we need them to expand access to medications like injectable hydromorphone and diacetylmorphine in appropriate formulations. And we can't forget that we desperately need affordable housing, basic income, social services, grief and trauma counseling, recreational therapy, and access to nutritious food. These lead to reduction in harm, as well as improvement of dignity, autonomy, health, and well-being of the individual and the community. In 2019, the Canadian Association of People Who Use Drugs published a safer supply concept document in which they introduced the idea of people accessing a legal and regulated supply of the substance of their choosing without criminalization. Under drug prohibition policies and policing, this concept is not possible, but that didn't stop a handful of physicians and nurse practitioners from acting based on the available evidence. Today, as we know, Safer Supply is a community-based program where people who use drugs are given a prescription for the medications that they need. And they also receive wraparound services, including physical and mental health care, along with support for basic needs. And we know that Safer Supply is not treatment. It's another harm reduction tool to combat the drug poisoning crisis. And with the research coming out of London, Ontario, a few months ago, indicating the 94% retention rate in their program, the potential for Safer Supply program is undeniable, and their scale up is essential. In light of the escalation of opioid-related poisoning deaths across the country, there's a great need for rapid expansion of Safer Supply programs, both during and after the COVID-19 pandemic. Similar to the guidelines from BC, our work in Ontario has been informed by the existing evidence base and the living expertise of people who use drugs. Our work in program development has been done in response to community level advocacy, which made it clear that we need community-based solutions and we need them urgently. I started working in Peterborough, Ontario in April 2021 on a Health Canada SUAP funded research project with a fairly small budget. The goal was to explore the barriers and enablers of Safer Supply programs, and with the option to potentially create a 10-person pilot program in June 2022. And that would be if we had the providers that from the community willing to join us and do this. There was an advisory committee of 6 clinicians when I started, but because Safer Supply is a harm reduction program and a program where people who use drugs need to have a voice, I turned this 6-person advisory committee into a 12-person advisory committee by adding people working in harm reduction. And then I also created a living experience advisory committee of 7 or 8 people to inform the research. I also hired a person with lived experience of opioid use, someone from Peterborough and with more recent experience than I have, to work with me on data collection and analysis for the section on people who use drugs. So first, I'm going to look at the focus groups that were done with people who use drugs. 4 of the 24 people I spoke to were housed at the time of this data collection. And of the people who were unhoused, 11 were in that position for, and the majority for 1 to 3 years. 21 of 23 participants said that they currently are using street-acquired fentanyl, and of those, 18 stated that they're using daily or almost daily. When looking at how people consume their fentanyl, 7 said that they inject, and 14 people said that they smoke. This points to the need for inhalation boosts at consumption and treatment sites because more and more people are smoking their fentanyl, and they are at great risk of drug poisoning, especially when they have nowhere to go to use their dope safely. 23 of 24 participants said that they're currently using street-acquired stimulants, and of those, again, 18 stated that it was daily. This supports the reports of increased polysubstance use and the need to be looking at safer supply for stimulants as well as for opioids. Drug poisonings are also more complex to treat when multiple substances are being used, so we need to be aware of this pattern. 20 of 24 participants said that they had drug poisonings in the past 6 months. And of those, 5 people said they had 1, 7 had 2, 5 had 3, and 3 people said that they had 5 or more. Half of the participants said they had done some sort of treatment for their substance use. Of those, 9 people had tried opioid agonist therapy, with 2 who said that they were currently on it. 6 people said that they had tried opioid agonist therapy 5 or more times. 2 had tried it twice and 1 had tried it once. This points to the need for more options for people who use drugs, because forcing people to repeat the same treatment options over and over again without achieving positive results is demoralizing and leads to a loss in hope and will to continue trying. We need to have more options. This slide is a mess, and I realize this, and it's a little bit hard to decipher. So 14 of 24 participants said that their nurse practitioner or physician offered them help for their drug use. And as you can see on this, more than half of the people offered OAT. And the remaining 10 people said that they wanted to be offered services and or support. So when asked what services they wanted to have, you can see on the pie chart on the right-hand side that it's a much more balanced pie chart where people want to have options. The message here is that people who use drugs want variety, but they want to know all of the possibilities so that they can make the choice for what best suits their needs. When asked if they would be interested in safer supply, because at this time safer supply was not happening in Peterborough, 16 said they were definitely interested, 7 would like more information first, and 1 said maybe later. Of those interested, 18 people said that their goal would be to replace the toxic street supply of drugs altogether. 19 people believe that safer supply would be successful in Peterborough. And reasons for wanting safer supply included that it would reduce crime, of which 21 participants stated that they had been involved in the last 6 months in order to obtain drugs, and that it would provide another option. It would get people off the streets and provide safety for the community. I spoke to people about barriers and enablers to opioid agonist therapy to start, so that they could reference something that they were used to and had gone to before. They called methadone liquid handcuffs because of how stringent and punitive the program is. They feel judged, stigmatized, and not heard by OAT teams, and access such as transportation and clinic hours were a barrier. Some enablers, although they said when it works really well and that it's easy to get on, they would prefer to go to their own physician or nurse practitioner than go to a methadone clinic. They want people with lived experience providing services, and they want options for counseling. When talking about safer supply, these were potential barriers and enablers. So again, judgment, stigmatization, and criminalization came up. Lack of choice in medications and doses. Not having access to affordable housing was seen as a barrier, and lack of support at the shelter. In Peterborough, the shelter system does not support harm reduction at this time, and but that is a work in progress. Some enablers to safer supply, they see this as another option for them, and they want to be treated with respect and trust. Again, having people with lived experience, they want options for appointments and medication delivery to be the option to go to the clinic or pharmacy, or to have it available on outreach. They want options in counseling, basic needs, especially housing was brought up, and they prefer going to their nurse practitioner or physician office, and they wanted culturally specific resources. Then I spoke with ordering and service providers and did some interviews with them for some demographic information. Of the people I spoke to, the majority were from Peterborough City or County, plus there were 5 from existing safer supply programs in other communities. And the majority have been working in their role for 1 to 5 years. The next 3 slides, the first one is the percentage of clients with substance use disorder within the practice. The second slide is going to be the percentage of those people with substance use disorder who have opioid use disorder. And the third slide is the percentage of people with opioid use disorder who are on OAT. I am going to go to highlight a few people so that you can understand the slides better. So if you look at participant E, it stated that 50% of their practice includes people with substance use disorder. Of those 50% of people with substance use disorder, 100% have opioid use disorder specifically. And And if we look at participant E again, of the 100 people, 100% of people who have opioid use disorder, 25% are being prescribed opioid agonist therapy. If we look at these same slides, but then look at participant K instead, we see that this participant has 100% of the people in their practice have substance use disorder. Of the 100% with substance use disorder, 100% have opioid use disorder specifically. And again, for participant K, in their practice, nobody is receiving opioid agonist therapy. I don't know this for certain who this participant was, but there is a possibility that this is somebody who is practicing safer supply. Most participants have clients in their practice who receive opioid agonist therapy. Half stated that they are prescribing or dispensing that opioid agonist therapy. Of the 11 people who could be prescribing or dispensing OAT, 8 of those 11 are actually doing it. 5 people stated that they're prescribing or dispensing safer supply, which was predicted from targeted recruitment. And 2 people stated that they're prescribing or dispensing opioids to clients with opioid use disorder, but they're not calling it safer supply. Of the 7 people, 1 person feels fully supported, with the other 4 saying that they feel either somewhat or not well supported. Of them, the 1 person who feels supported is the 1 person who has cross coverage. So support, that means that they have support from other prescribers to cover their caseload when they're off or after hours. This really points to the fact that we need to have more people doing this prescribing so that there's more support. Looking at barriers to opioid agonist therapy, the program model is too regimented and not accessible, lack of individualized care, poor retention rates, client experience includes stigmatizing judgmental care, lack of communication and privacy, and that it's not addressing basic needs or pain issues. Some enablers to opioid agonist therapy, they want it to be more flexible and accessible. They want it to have holistic care. Clients need choice in their medications, access to health and basic needs need to be met, and clients should be able to set and work towards their own personal goals. Some barriers to safer supply, sustainability. The financial sustainability is definitely an issue that everybody is working on. People want more evidence, was brought up, and I would argue that there is evidence out there to support it. And also with innovative care, we need to push with that evidence. Accessibility was an issue. The community judgment, stigmatization, criminalization, again, was a barrier. Lack of choice to get meds that they need, and lack of access to basic needs. Some enablers to safer supply, we need a flexible and accessible model. Need for education and buy-in from the community, holistic supportive care, stable funding is required. The client experience includes more choices in medications, increased communication and trust, and access to basic needs. I just want to point out that the one thing that was in every part of this, whether it was with safer supply or opioid agonist therapy barriers and enablers, that access to basic needs and especially housing kept being brought up. As I mentioned, I started with a fairly small budget and a plan to maybe do a 10-person pilot. But I was the only staff that was hired for this project, and we were uncertain how we could actually provide this, the support that individuals needed, even for just 10 people. When additional money was made available for existing SWAP programs, I applied for an amendment, and we were told that we would need to operationalize that proposal quickly if we got the funding. And in December 2021, the announcement was made that our amendment was approved. We now have approximately $1 million budget from Health Canada's SWAP. It is based out of a nurse practitioner-led clinic with plans to include an outreach component as per the research. Safer Supply Frontline team consists of health, social, and harm reduction services. with the majority of people working on this team having lived experience. It's a 50-person pilot program with gradual enrollment having begun this month. Program planning, implementation, evaluation will be guided by the research project and the advisory committees. Rely on community partners, especially our harm reduction partners. Going to lead public education and awareness presentations in the creation of a local community of practice, and robust research and evaluation to continue with participants, staff, and the community. We're also doing an additional piece of research within our Safer Supply program evaluation. We have partnered with Apothecom to study the usability of Sterifilt filters among participants who inject drugs. Sterifilt filters are the newest filters that they have from Apothecom, and you might be familiar with their earlier versions. These filter membranes remove any large unwanted particles that are in the crushed pill or drug. These particles, if left in, are what cause the irritation to the lining of our veins, which then leaves the irritated area open to infection if bacteria or fungi are introduced. The good thing about the Sterifilt Plus is that the filter membrane is fine enough to also remove any bacteria or fungi that may be in the water or the drugs that is being filtered. So as long as the prepping of the skin and following best practices, a lot of the risk that may have been outside of our control is taken away. 50 people on a program is not large enough of a group to study the effectiveness of the Sterifilt filters, but it is enough to get an understanding of the uptake of using them and the experience of using them. We're going to ask participants questions about their methods of using drugs at intake, and then again 4 months later after having the opportunity to use the Sterifilt Plus filters. Although we are only offering it to current Safer Supply participants, our hope is that this could change the availability of this product in the future. I also want to, while I've been talking about Safer Supply programs and the urgency to scale them up, I'm also very aware of the fact that just like we cannot criminalize our way out of the drug poisoning crisis and related social injustices, we also cannot medicalize our way out of them. There is no way that the medical system can keep up with the demand for safer supply. So with this work, we are also responsible for demanding the defunding of policing and prisons and pushing for decriminalization of drugs. Without these two shifts in policy and practice, we will not be able to end the increasing rate of drug poisoning deaths that we are seeing today. Decriminalization and safer supply alone won't stop the number of deaths that are currently occurring, and 20 people dying every day in Canada is simply unacceptable. Drug use is currently a death sentence, and we need to change this. In order to change the trajectory of deaths, we need decriminalization, legalization, and regulation, similar to what we have with cannabis, but cannabis isn't where we want it to be either, because policies are making the expungement of criminal records of those who have been criminalized for simple possession cumbersome and often difficult to get. The current supply of street drugs is toxic. It is killing people, and prohibition is to blame. Just like what happened with alcohol when it was prohibited, we keep getting stronger and stronger products so that you get more for less. Opium to black tar heroin to white powdered heroin to fentanyl, carfentanil, and now benzodope. What we're witnessing is a supply-initiated change. Regardless of the preferences of people who use drugs, the changes are likely here to stay as long as drugs aren't legalized and regulated. And it is not only impacting people who use drugs, it is also impacting people who use all drugs and through cross-contamination. You may have heard of Bill C-216 that was brought to the House of Commons by NDP Minister of Parliament for Courtney Alberni Gord-Johns. In order for the bill to pass, there are a bunch of steps that need to happen. There have already been 2 readings for Bill C-216 in the House of Commons. The first one was to explain the purpose of the bill, and the second one was to debate the bill in principle. The vote to move this bill from the House of Commons to the committee stage is next week on June 1st, 2022. The steps that follow would be that the committee reviews the bill, public hearings may occur, and then amendments are considered. The committee then reports the bill with any amendments back to the House of Commons, and the bill is voted on for final approval during the third reading. So we're not there yet with this bill, but it is moving. So what is this bill and what does it mean? Are the aims? The first one is decriminalize simple possession of drugs listed in the Controlled Drugs and Substance Act. So people who use drugs don't face or fear criminal charges, especially when seeking life-saving support and services. Number two, provide a path for expungement of conviction records for those convicted of simple possession. So people who use drugs no longer face discrimination because of past convictions that should never have happened. This process, it should be superior to what currently exists for cannabis. And develop and implement a national health-based strategy to manage the risk of drug poisonings through access to a regulated, safer supply of drugs, and expand trauma-based treatment programs throughout the country for the people who choose to access them. Drugs aren't going anywhere. So how can we alter the landscape so that people who use drugs can use their drugs safely and stay alive? First, we need a safe supply of drugs so that people don't die. We need to regulate this market so that the drug supply is no longer under the authority of criminal organizations. And we need this safe supply of drugs to be available to people who use drugs without needing a prescription. The role of drug choice and distribution needs to be put back into the hands of the people who use them. Thank you.
Thank you so much, Nancy. What an amazing, comprehensive, and powerful presentation. Thank you, thank you.
Thank you.
Like to do two things. One, before we turn it to the question and answers, we're just going to throw a poll up really quickly so we get some information about where our attendees are coming from today and their experience with our presentation today. So Vola, if you could, thank you. So there's a poll. If you could just take a minute and quickly respond to these 6 questions. I also invite people to put any questions that you have or responses to the presentation, any questions for Nancy, thoughts, comments to Nancy in the question and answer box, and we'll have a look at those. So there's a couple of questions. One, there's a very simple question to get started with. Nancy, from Rebecca, asking about your research findings. So the work that you've done around the needs assessment for Peterborough, is that published or posted anywhere? Is that available for people to refer to at this time, or will it be?
This is a little bit of preliminary results. I'm speaking before the report is actually out. So it's in process and should be out fairly soon. I will definitely share that with the group as it's available.
And we'll add it to our resource collection. In the chat, it was pointed out that there are a couple of other evaluation reports that are out there that people can call upon if they're looking for some support for writing proposals and things like that, and talking about evidence. That there's the London Intercommunity Health Centre program evaluation. There's also an evaluation of SWAP funded programs that's that was done by Health Canada, sorry, and those are both available on our website. Okay, another question. Again, I'm just doing a couple of quick questions first. There's a question from Richard about Sterafilts and their cost, and how, is it possible that they could be available through needle exchange and safe consumption programs? And of course, it is depending on cost. So it's just looking that up.
They're expensive.
Yeah, they are expensive, and it's why most places don't have them. It's 36 euros for 100 pieces. So let me just do it's $50 for 100 Sterafilters. So Sterafilts. So yeah, not cheap. I think there is effort to include funding. Like, I think more and more programs are putting in funding for supplies like that, equipment and supplies like that. Oh, Jolene has here that it's 20 Canadian cents a piece. And Sarah comments that they are always on back order in Washington State.
Oh, interesting.
Nancy, I also just want to point out that there's some thanks for your presentation, for your willingness to share your knowledge and experience and all of your advocacy. So I just want to make sure that you are aware of that in our chat box there. Rebecca's called out a couple of things that are happening that have been happening in the community. One is the release of the report from a research team at Simon Fraser University. It was a review on the public supply of addictive drugs, and it was funded by the Alberta Ministry, and had it stirred up quite a bit of response from other academics involved in research around harm reduction, and evidence around interventions for people who use drugs. Do you have any comment on that review? I'm not sure if you've had a chance to look at it, or.
Yeah, I haven't looked at it close enough to be able to make really broad comments about it, unfortunately. My apologies for that. I've heard about it and been talking about it with people, but yeah, I'm not well versed enough.
And along a similar theme, Carla points to a panel that's happening on June 7th that's being hosted and organized by University of Waterloo School of Public Health. There's a link I can share in the chat. I'm not sure if everyone can see it. I'm encouraging people to actually register for this panel and send in questions. So it's a panel of people who I would characterize as not particularly supportive of safer supply. Is there anyone who'd like to speak to that panel? It's a lecture, Moving Forward by Slowing Down. I'm just trying to see if it has a description here. So it is around sort of like, yeah, kind of pulling back a little bit from the topics of decriminalization, medicalization, and legalization.
And to Richard's comment that 20 cents isn't that expensive, it definitely, if they are beneficial and they prevent a lot of harms, then I agree that the cost would be worth it. So hopefully that with them agreeing to do this study with us, that we can move that forward a little bit and get them available with harm reduction, because they should be there with the supply.
Thanks, Nancy. Kareem writes, why is it that people are still incapable of seeing that the criminal approach and the health disease approach are two sides of the same coin? Thoughts on that?
That the health approach, sorry, I have to.
Yeah, the two sides of the same coin, that there's criminalization on one side and the health disease or the medicalization is on the other.
Yeah.
And it is interesting because there, is there only two sides to this, two ways of looking at this? Another question here is, in the nursing profession in Canada, what's the general attitude opinion towards drug use. Are people in your profession generally on board with harm reduction at this point, with safer supply? My dog thinks they should be. Or is there pushback? And the person asking the question acknowledges that this might be a really hard question to answer, but would appreciate any of your thoughts.
Yeah, I unfortunately, harm reduction is not covered in very much in schools for nursing. I think it's across the board for healthcare professions. It is like a day of a community course that they do, and then there's another day that they do it in their often in their mental health and addictions, or not addictions, their mental health course. So a person that I know who just graduated a couple of years ago said I was a TA in one of the classes, and they said that was the only time that they heard about what's happening with harm reduction. So yeah, it's not being talked enough. And so nurses are entering their profession without that knowledge. So I think that there needs to be a lot more in the education system. I think a social justice kind of course would be helpful for a lot of students, so that there's more understanding of substance use and harm reduction options. And anything that's new and innovative is not going to be in that textbook that they're covering for those courses. So unless they ask someone to come in and speak about it, that information just doesn't ever come across their desk.
Thanks, Nancy. There's a couple of comments. I've just been trying to catch up a little bit with what's happening in the chat, and a couple of people have reflected on the fact that either like Carla is actually teaching the stuff in Carla's work as a nursing prof. But another person, Kim, mentions about how in rural Nova Scotia, many nurses in emergency rooms are very stigmatizing, that Kim and others are working to try to develop training and such for nurses in their local hospital, and also Kim mentioned that they'd like to connect with you about the presentation that you have here.
For sure. And yeah, of course, it depends on the school, and it depends on the person teaching the course, what quality of harm reduction information is going to be shared, for sure.
I think your point though about how when we're always on the edge of trying to push services forward and develop innovative and creative approaches to an ongoing and constantly evolving crisis, it can be hard to have that teaching happening in real time unless people are connected right into the communities there. And I know there's a lot of organizations or a lot of universities that will invite people who use drugs members of organizations of people who use drugs to come and speak to the topics of providing care, which is also really important. Richard comments here, unfortunately, there are a lot of health professionals who subscribe exclusively to the abstinence model. They sometimes have disproportionate influence on decision makers, and it's very difficult to change their views, even with good evidence. And that's such an interesting point, right? Because we are talking about, we hear so often, as you mentioned in your presentation, Nancy, that there's, people will say, well, there's no evidence, like they're waiting for the evidence. But we, as you've shown, Nancy, and we have 700 articles or 700 pieces of materials that people can call on from our database, things that people can call on to help support their work in harm reduction and this approach of safer supply. So yeah, evidence isn't always the magic bullet. And we know that medicine and clinical practices and social practices do evolve and while evidence is being accrued. So It's interesting, Nancy, with decriminalization, like there's so much happening in the media right now around decriminalization and it being a solution. And I think it's always really important. I get really frustrated with the excitement and around decriminalization, because I think that unless it's coupled with the kinds of care and support and approaches that you refer to, addressing social determinants of health, like housing and access to food, trauma counseling, and access to a safe supply of drugs, a regulated supply of drugs, be it through a medicalized model or non-medicalized model. I'm not sure that decriminalization is going to be the magic solution. I think it helps address pieces, obviously the criminalization piece and helps address stigma, but it doesn't address the poison drug supply. Any other thoughts or questions for Nancy? I have a bit of a personal question, Nancy, because you did share with us about your experience, your journey navigating through all kinds of different systems, the shelter system, medical system, and academic systems, and in your current work right now. How are you? Have you found that your capacity to draw on your different sources of knowledge and expertise has been a source of, has that helped you with being able, like you can call on the medical things, you can call on your lived experience. Has that helped you with advocacy and your work?
That's a great question, Rebecca. I believe it has. All of those things together have, but only in the last few years. I went through a very long time where I didn't draw on my lived experience. I carried I carried shame, I carried doubt, I didn't see that, I didn't feel like it was valued, and I felt that it was something I had to hide. So I didn't call on my lived experience. I didn't speak about my lived experience for a very long time, but I realized that that's harmful, and I'm perpetuating that shame and that stigma and all of those things by not speaking. So and that was a shift that happened through hearing other people, through realizing that there is that. One person claimed, who I've heard speak, says that they feel that they're finally being heard, and I think that we aren't necessarily, everyone isn't being heard in all of the right places at all the right times, but there has been a shift over years that lived expertise is valued a little bit more, but we have a long way to go with that.
Thanks, Nancy. Petra, thanks, Petra. Petra's just highlighting some resources here regarding advocacy for Bill C-216. And Nancy, as you were presenting, a couple of people were sharing some information. Petra and Shari were sharing some information about that bill. So I've just plopped that into the chat. Petra shared about a script from a ZAP event, which includes a sample letter to MPs, phone scripts, and sample tweets. Petra encourages everyone to contact their MP in support to getting Bill C-216 to committee. And you'll see that in the chat there. Great. So we're just coming to a close. Alex, can I'm going to ask if I can have you share about our June event. After I just say a big, big thank you to Gabrielle, who has been typing madly as Nancy speaks. Gabrielle, thank you for your expertise, your skill, your time, your work, your energy. Thank you. And Nancy, thank you so much for your very, like a very comprehensive and very powerful presentation. I'm really grateful that you're here, and I'm really excited about the work that's happening in Peterborough. Thank you, thank you.
Thank you.
Alex, tell us about what's happening in June.
Sure. We have what event? Which one? Because there's like kind of three main things that are
happening. Too many. The Hot Topic event in June.
The Hot Topic. Okay. So we're gonna do a Hot Topic on June 30th. I'm just gonna get the link. Sorry, I didn't have it ready. I didn't have the link hot. It's gonna be it's gonna be kind of a two-part session. So the first half is gonna be a presentation from one of the community of practice members. She's a chemist and self-identifies as a nerd. And is going to talk to us and give a presentation about urine drug screenings. And then following the presentation, we're going to have a panel discussion of people who use drugs, a number of whom are our parents or guardians who use drugs. And so we're going to be talking about the sort of implications of the use of urine drug screenings and the results that come from those on the lives of people who use drugs. So the list of speakers is tentative for the moment, but I'm happy to share the link to give you a little bit more information about what we'll actually be talking about.
Robin's just done.
Robin's already done it. Thank you. Yeah. Thank you. So hope to see you there.
Yeah, it should be really great. So that's our next public event. Members, we have some exciting regional meetings happening in June, one in Toronto for Ontario regional meeting happening June 7th. There's a waiting list now, we're sold out, but feel free to join the waiting list because you never know. And then June 27th, we're having an Atlantic regional meeting in Halifax. And yes, those are the two things. And then every Thursday we have our members only drop-in meeting time for the first, all Thursdays except for the last Thursday of each month. Yeah, lots happening. So yes, thank you all for coming today. And yeah, do you want to hang on a minute, Nancy, to debrief? Yeah. Okay. Thank you all, everyone. We hope you'll join us again, and we will be posting this on our website.